Bonjour à tous.
Good morning and welcome to Epicentre Scientific Day. I'm pleased
D'introduction, surtout parce que c'est quand même
and honored to introduce this particular scientific day because we're going to celebrate the 40th anniversary of Epicentre. And now I'm inviting the moderators of the TB session to join me on the rostrum. Thank you.
Bien, merci.
Thank you very much, Marilyn, and thank you to the team of Epicentre for having invited us to moderate this first morning session on TB, tuberculosis. There will be 3 presentations, and then we'll have a short Q&A session. Before starting, since we are celebrating our 40 years, maybe we can have an overview of what MSF has done, or Epicentre has done on TB over these years. The TB activities started with reports in the 1990s assessing some MSF programs. And I think it started in Guinea, and then there were a few others covering Southeast Asia. And then there was a new step in the early years of the 2000 decade. It's not a coincidence, a correlation is not a causality. When Marilyn joined the Epicentre team in the midst of the first decade of the year 2000, with a new momentum, we organized ourselves differently. We became stronger from the scientific viewpoint, and the first papers was the Carinemo research, which was made with the OCG in Mozambique on the efficacy comparing 2 drugs with on positive patients, on HIV patients. HIV was a driver of our research on tuberculosis in the early days with self-administered treatment. The incidence of TB in HIV patient cohorts, and it still is a very important topic, this co-infection, and hopefully this will result in operational case management in the field, managing both diseases. Diagnosis is key in tuberculosis, as you know, for tuberculosis. It has been the object of many research studies with all these abbreviations, BLEACH, the colorimetric studies, the TLA, the FAST-Plaque, which resulted in a major failure. We were successful, but not always. There were various methods. I could also mention TLA, so I've already mentioned TLA, and the SMF of the filtration project. Not everything did work out up to the lab, which is a more interesting method that we have at hand today. In addition, we started some clinical research on treatment solutions because there is this drawback. We're talking about long-haul treatments and increasing the dose of rifampicin, which is the basic treatment to reduce the duration of treatment, was something Epicentre started to work on with other partners, and we'll talk about it again later. There was the IREF study at the same time as the development of high-level labs in Uganda. There were other studies such as the STATIS study on the empirical treatment of TB on patients who were HIV positive. We were looking into all these diagnostic tests, which we realized was more interesting than the empirical treatment. All these studies have helped to improve the case management with tuberculosis, meningitis, and more recently, the short-term treatment, 4-month treatment. But the treatment is also the advent of delamide for resistant TB. Very quickly, we started studies which have shown the efficacy of the treatment. We have described that in our programs. And Kathy, even though she's at MSF, has greatly contributed to these studies up to the end TB trial, and more importantly, the work on safety and effectiveness in all the countries with interesting output in the framework of this consortium study. And then there was pediatric TB, TB in children. The whole range of studies on TB speed with diagnosis capacity reinforcement, the objective to reduce mortality, resulting in a series of research studies with the tactic program, which is a result of all these efforts. So we've carried out all these studies. You can check that on your favorite website, that of Epicentre. But there are some lessons to be drawn from this research, because this research has had some impact beyond MSF. I forgot to mention there's the reduction of the number of expectorates to start the treatment. There is all the research on resistant TB, and this has had an impact up to the WHO in Geneva in the decision-making bodies and the recommendations issued by international organizations. I would also say that Epicentre started to focus on tuberculosis rather late in its history. Not necessarily for a strategic region, it's also pretty much people-dependent. We focused much more and earlier on other diseases, more than on tuberculosis. And also, I think that all the research on TB at Epicentre shows all the problems related to TB we have identified. The diagnosis, no study on vaccines, for a good reason that there is no vaccine. There is only the BCG vaccine, but hopefully things will change. There is also the question of the management of resistant TB to first-line treatment. All this was artisanal. I think that all the work of Epicentre over the last years does reflect the interest we now have in this. This is another comment I would make is about the adaptability of the organization that is making decisions internally, hiring the right people. I'm thinking about statisticians. I don't know whether Matthew is in this room. Matthew Bastard has played an important role in all the statistics on TB, as well as Isabelle Baudin. And our internal capacity to have more staff for TB in our teams was also important. Not only researchers, we were also involved in multi-centered trials. We bidded further to calls for proposals or bids for international studies and others which were more specifically organized for MSF. And we also organized a specific scientific day in Uganda on tuberculosis. Our colleagues in Uganda have played a pivotal role in all the work on tuberculosis with the famous laboratory that we have there and all the investment made there. And this is reminding us what Marilyn said in her introduction. There is the intangible link as it was defined in the past, this very close ties between MSF and Epicentre. So there is the research agenda. First of all, we meet the needs of our operations. Of course, there are international bids, but everything stems from the questions raised by our healthcare professionals in the field. And there is also the long-term commitment to MSF in this area with the Mbarara lab with a negative pressure laboratory. It's a very high standard laboratory, allowing to carry out studies, but also be an entry point for partnerships. We don't work on our own. That's important. We are connected to MSF, but we're not the only ones. We've had many partners throughout this tuberculosis saga. One of the last questions we may ask is whether this meets actually the needs of MSF and what MSF does about that. And I have next to me the best person to answer this question, and I'm giving the floor to Kathy Hewson. You have the floor.
Thank you. I remember my first day in the medical department. The first person to call me was Marilyn Bonnet. So since day one, for me, I don't know why we say MSF, Epicentre, and MSF, it's the same thing. And the work that we do has real impact on what happens in the field, whether it's local in changing practices, finding tools that are adapted to our contexts, like thin layer agar, knowing what we're treating, doing a drug susceptibility survey to know what is the resistance in your area. You know, we were the first ones to do that in some areas in Africa where they had no idea what they were treating. Even convincing WHO that resistance was a problem. I think they stopped talking to us for a while. But also nationally, at level of guidelines, of programming, the studies you'll see today have impacted hugely the national policy, and that is the same for many of the studies, but also globally. I think one of our biggest goals is to have that global impact, and sharing good quality data is the best way to do that, and we have so many examples of that. But doing that also has other impact. If we look at the sort of advocacy and access, we look at the, you know, by creating a market, introducing those new molecules in the NTB observational study, and then in the clinical trials, shortening treatments, there was a market for those drugs, and the price of those drugs have plummeted to what I never would have thought would happen, to under $500 for a treatment. There's also impact daily. If we look at the use of TB-LAM in patients who are living with HIV, it has a direct impact on mortality. And it was only the MSF person in the room in that guideline review who, without data, convinced the rest of the people in that room to put that in the guidelines. So I think, you know, good quality data has a direct impact every day in our projects. And even in terms of very practical things, today you'll hear about some computer-assisted diagnostics. This is artificial intelligence for reading X-rays. Sounds easy, just plug in the box, but how do you calibrate that to your context? And it's the work done on research that has really helped local contexts to adapt to their needs. Earlier, somebody said to me, but there can't still be TB on the agenda of the Epicent Scientific Day. Isn't it finished TB? But no. TB, we have to chip away, we chip, and we get a little bit further every time, but it's a long and slow process. There's no miracles. And I think one of the areas that has been most challenging for our field teams is the management of TB in children. And this came directly from the field, you know, seeing children who were diagnosed too late and would die from tuberculosis. And this is not just a problem in MSF projects. Globally, 50% of young children are never diagnosed, and 97% of them die. So in 2022, when WHO came out with some new recommendations, on the diagnosis of TB, so some treatment decision algorithms to help us diagnose TB clinically, which is very important because we do not have a good test for TB in children. The tests we have do not work in children because they have very few bacteria that the tests we use in adults cannot detect, but also on the treatment and the prevention. So I'm very happy to say all sections of MSF and Epicent and other people came together to say, okay, let's seize this opportunity. And that was the creation of the TIC-funded project TACTIC, Test, Avoid, Cure TB in Children, TACTIC. And this project has 3 big pillars. The first one is implementation, implementing those guidelines. And this year, 12 countries, 6 operational centres, 53 projects have diagnosed over 5,000 children with TB. This is a huge increase, at least double and probably more in most of the projects. Over 1,000 health workers trained and an incredible impact on the daily work on children with tuberculosis. The second pillar is advocacy, and the results you're going to see today have already hugely impacted globally and locally, nationally, advocacy, changing guidelines. Countries are updating their own policies based on our experiences. But then we come to the third and very important today pillar, is the operational research. There's 2 big studies in TACTIC, and you'll hear about both of them today, TB Algoped and the 4-month. And they've enrolled over 1,500 children. They're incredible studies, and let's hear about them now. So I'm going to introduce the first speaker. So would you like to come up? So this is, I'm very happy to introduce Dr. Mohammed Bashir Abdullahi, who's a medical doctor. He's joined MSF in 2018 for emergencies on cholera and measles in the project in Maiduguri in Nigeria. And in 2019, he joined the nutrition project, and he is really an expert on children with severe acute malnutrition and their complications. And he joined us as the study coordinator on the TB Algoped study in 2023. I've really had the pleasure to see Dr. Bashir in many global conferences around the world and locally in Nigeria and elsewhere. He's really an expert and has a great way to pass on these messages. So over to you, Dr. Bashir. Thank you.
Thank you. Thank you, Kathy. Good morning, all. I will talk on finding tuberculosis in children in severe acute malnutrition. This is a multi-country observational study. Good. So we know diagnosis of TB in children generally is very difficult because their symptoms are not very specific like we see in adults, and the laboratory tests usually come back negative because of the low bacterial loads in those samples, and sputum samples are very difficult to obtain in children. But the diagnosis is even more difficult in children with severe acute malnutrition because a child with SAM comes with weight loss, and weight loss is a symptom of TB, and you may not be able to differentiate between weight loss from TB or from food insecurity, especially in contexts where we have high volumes of children coming to facilities with severe acute malnutrition. And most of the times, those children are very sick, and they come with other comorbidities, which is also very difficult to differentiate from TB. So, like Kathy mentioned, in 2022, WHO came up with these treatment decision algorithms to improve diagnosis of TB in children, and requested for validation from organizations, countries, to ensure that these are adapted to settings in real life. So in MSF, we conducted the TB Algoped study, which started in 2023 up to the end of 2024 in 5 countries. And this is to validate the algorithm. So in this big study, we have some nested studies. The first one is the TDS in SAM. So we needed to validate children with SAM using this algorithm, and the objective was to assess the diagnostic cascade as well as the accuracy of those TDS in diagnosing TB in children with SAM. Then, secondly, the second nested study is the TB LAM in SAM. We know that WHO has validated the determined TB LAM point of care urine test for diagnosis of children living with HIV, for diagnosis of TB in children living with HIV. And we know that children with severe acute malnutrition also have a form of immunosuppression, and we thought that determined TB LAM and Fuji LAM could be helpful in diagnosis of TB in those children with SAM who are HIV negative. So we assess the diagnostic accuracy of the TB LAM test in those groups of children, the SAM who are HIV negative. So the TB AlgoPIT study conducted in 5 countries. It's a diagnostic prospective study. Children under 10 years were enrolled into the study with signs and symptoms of pulmonary TB. The countries are Niger, Nigeria, South Sudan, Uganda, and Guinea. So for the TDS in SAM, we conducted it in 3 countries where we have high volume of children coming in nutritional facilities with severe acute malnutrition: Niger, South Sudan, and Nigeria. The population is children with SAM. And then the TB LAM in SAM was conducted in these three countries plus Uganda. And in Uganda, it's a referral hospital as well as rural health centers. And the population was children with SAM and HIV negative. So this is the WHO treatment decision algorithm, and we followed this algorithm in the diagnosis. So when a child is identified as having symptoms of pulmonary TB, they are put into this algorithm, and then because they are all SAM, then we test the molecular, WHO molecular test, which is the gene expert, and also the TB LAM for those living with HIV. And then history of contact was also asked. And then for centers where we have X-ray, it was conducted. And then we scored the children using algorithm A, which has signs and symptoms and chest X-ray findings. And then the algorithm B have only signs and symptoms. So whenever the score is more than 10, we start them on TB treatment. But when it's less than 10, we review them in a week and rescore them. So the study procedures in the TDS in SAM, we followed the same algorithm pattern for the WHO, which is clinical exam, algorithm score, gene expert test, X-ray, TB LAM in HIV positive children. We reviewed them in a week, and then we also followed them at 2 months to see how they were doing. And then the TB LAM in SAM was basically children with severe acute, children who are HIV negative. We conducted the determined TB LAM and also the Fuji LAM in those kids, but the results were not used in treatment decisions because they were blinded to the clinicians. So now talking about the results of the TDS in SAM, most of the kids were under 2 years, and then most of them were hospitalized, and around 2% living with HIV, and around 23% started on TB treatment. The steps of the algorithm in these 3 countries, Nigeria, Niger, and South Sudan, most of the kids had gene expert test done because we had it in the facility, as well as the algorithm score, which is the WHO scoring system. But most of the kids had X-ray done in Niger, but in Nigeria, only 22% had X-ray, and then none of the kids had X-ray in South Sudan because we do not have X-ray in South Sudan. So looking at this, we can see that irrespective of the capacity of testing, whether gene expert or X-ray, you can score the kid with the algorithm. This is also a very important finding because we can see that from the main reasons for treatment initiation, out of the 245 kids started on TB treatment, majority, more than 70% of them were diagnosed based on the scoring system, and around 12% were based on history of contact with someone with TB, and around 9% of them based on the gene expert testing, and only 0.4% diagnosed based on positive TB LAM, and these are kids living with HIV. Talking about the accuracy of the algorithm, we found a sensitivity of around 84%, and also a specificity of around 85%. And we use the reference standard classifying TB according to the international consensus case definition for children. Now talking about the results for the TB LAM in HIV-negative children with severe acute malnutrition. So 990 kids were enrolled in this study, and then most of them were under 2, just like the other one. Then the accuracy of the TB LAM. So the determined TB LAM had a sensitivity of around 38% and a specificity of around 64%, while the Fuji LAM had a sensitivity of only around 12% and a specificity of around 96%, very good specificity. And we use the same reference standard as the one in the TDS in SAM. So in conclusion, in settings where we have high food insecurity, we implemented those algorithms, and we saw that the main reason for starting TB treatment was the clinical and radiological score. Even though, regardless of whether you have access to gene expert or not, or X-ray or not, we saw this was the most important reason. And then the TDS show a high sensitivity and an acceptable specificity, while in the second study, HIV-negative children with SAM, we saw that the determined TB LAM had low specificity, and the results do not support its use, while the Fuji LAM showed high specificity, and this could have a potential as a rule-in test. Talking about the impact and perspectives of the study, it had a lot of impacts across these countries. We conducted several trainings to ensure, to ease the implementation of the algorithms in several facilities, MSF and MOH. Also, we conducted roundtable discussions at national levels, which impacted the practices and the ownership of these algorithms. And also, it led to policy change in most of these countries where the algorithms are integrated into the national guidelines. And in terms of the perspectives, we think that the TDS can be used in large facilities where we have large numbers of children coming in with severe acute malnutrition. These are nutrition facilities and can be adapted to each context. And we think that in the future, probably new urine-based TB LAM test may have potential in TB diagnosis in HIV-negative children with SAM. I thank all our study participants and research team, as well as partners, for helping us in this study. Thank you all.
Thank you very much. That was very clear. Thank you, Dr. Bashir. Juno, would you like to come to the stand? So I'm very happy to introduce Juno Min, who a lot of people here know because he is the intersectional diagnostic advisor and radiologist at MSF. He's been working with MSF since 2011, and he's been in his current position for about 6 years. And he's really interested in clinical use of diagnostic imaging and developing X-ray interpretation curriculum. So lots of trainings done by Juno and providing support to MSF projects. And he's been involved in a lot of research projects, a lot of TB research projects, and he's really leading the research on everything to do with artificial intelligence. Thank you, Juno. Go ahead.
Thank you, Kathy. So this morning, I'll be talking about our study evaluating AI-based technology called computer-aided detection for chest X-ray interpretation for TB diagnosis in children. So we know that the diagnosis of TB is difficult in children, and that most children with TB are never diagnosed. Chest X-ray does play a critical role to support TB diagnosis, but is really not easy to interpret in children. Also, countries with the highest TB prevalence often have the lowest availability of expert chest X-ray readers, such as radiologists. There has been development of this new AI-based technology called computer-aided detection, or CAD, which can support chest X-ray interpretation for TB in adults, but is not currently recommended for children. In 2021, WHO performed an independent evaluation of CAD and released this recommendation, endorsing the use of CAD for chest X-ray interpretation for pulmonary TB, but only in individuals aged 15 years and older. Since this recommendation, there's been an explosion of the use of this technology, with thousands of these CAD units being used worldwide in many different countries. In MSF, we've been using CAD since 2022, and currently we have implemented CAD in 5 different projects, primarily for TB screening. We're using it for screening in the community to support human readers, such as active case finding, but also using it for facility-based screening, such as in hospitals and clinics. So to give you a quick demonstration of this technology, we have your digital chest X-ray, and CAD can be used with any machine that produces digital images. This image is analyzed by CAD. It gives you, the output comes in less than a minute, and it gives you a color heat map, but more importantly, a CAD score from 0 to 1. To interpret this CAD score, it's necessary to identify or select a threshold, for example, 0.5, above which patients will be referred for confirmatory testing. So in this case, with a very high CAD score, sputum was collected from the patient, they were referred for confirmatory testing, and TB was confirmed. So why is CAD not currently recommended for use in children? The current CAD models are mostly trained on adult chest X-ray data sets, and there's a lack of quality pediatric data sets. The chest X-ray appearance of TB is quite different in children compared to adults. There's 2 examples on the right side with classic appearances of TB on chest X-ray in an adult and in a child. And you can see it's quite different in these 2 X-rays. So a CAD product that's been trained to detect TB in adults may not perform well in children. In addition, there's been a lack of studies assessing CAD performance in children. So to address this gap, we designed a study to evaluate the performance of CAD in children as part of the TB AlgoPED study. There were 4 sites involved: Guinea, Niger, Nigeria, and Uganda, and the study cohort included children under 10 years with symptoms of TB, an available chest X-ray, and valid CAD scores. For the chest X-ray, we only use the frontal chest X-ray in a digital format. This could be DICOM format, which is the best diagnostic quality, a JPEG format, or in sites that are still using the old film and chemical processing, we took a photo of a hard copy film. For the CAD, we used a product called QXR, and we used the specific version which was trained and optimized for pediatric TB. As the reference standard, we used expert radiologist interpretation, which was a consensus of 3 external independent readings. Some of the characteristics of the 665 children included in the study: you can see the median age is 1.5, so it's quite a young cohort. 9% were living with HIV, and over 3/4 were living with SAM. 25% were diagnosed with TB, but you can see that only 13, so about 2% of the entire cohort, had laboratory-confirmed TB. And this is consistent with what we've heard with in terms of the low rates of lab-confirmed TB in children. So to assess the CAD performance, we generated these receiver operating characteristic curves, or ROC curves, which plots the true positive rate or sensitivity on the vertical axis and the false positive rate on the horizontal axis. And we plot these values for every single possible threshold to generate this curve. For example, at a threshold of 0.655, the sensitivity was 86% and the specificity was 53%. Then we measure the area under the curve, which gives you a value between 0 and 1. In general, an AUC above 0.8 is considered clinically useful. So overall, for our entire study cohort, the AUC was calculated at 0.76. So the CAD is showing fair performance for pediatric TB. It's not good, it's not bad, it's somewhere in the middle. This is the CAD performance broken down by the 4 country sites. We can see the ROC curves on the left and the AUC values in the table. There's a decent range here from 0.68 to 0.87. However, it's difficult to make comparisons between these countries because there was quite a difference in the population characteristics and also in the image format that was used as well. And you can see that in the right-hand column. However, in general, the sites that had the better image quality, Nigeria and Uganda, showed better performance with AUCs reaching 0.8 or above. So discuss some of the challenges involved with this specific technology. Image quality. We have seen that image quality affects the CAD scores, but this also affects human interpretation as well. And there are 2 aspects of quality. One is the image format, and there can also be technical factors, such as the positioning of the patient. To illustrate this, there are 4 bacteriologically confirmed TB cases that I'm showing below. All of these show chest x-rays that are suggestive of pulmonary TB. So they all should have high CAD scores. However, you can see there's a huge range in the CAD scores that are produced, from 0.88 all the way to 0.09. But if you notice the 2 chest x-rays on the right, these were photos of hard copy films, and the quality is not very good. And I do believe that the quality of these images is at least one of the reasons why the CAD scores are so low. 2, lymph nodes. CAD has difficulty detecting enlarged lymph nodes. This is probably the most challenging thing for human readers as well. The 2 examples on the right, these are both confirmed TB cases, and both demonstrate quite significant intrathoracic lymphadenopathy, as illustrated by the red arrow. These both should have given high CAD scores, but you can see the CAD scores are below 0.2. So the CAD is not picking up these lymph nodes. The lateral chest x-ray. Most CAD products do not accept the lateral view, but we know when we're reading chest x-rays that the lateral view is quite important, particularly for pediatric TB, and is currently recommended by WHO. The imperfect reference standards, both to train and evaluate our CAD models. We are using the radiologic reference standards, so expert readers. However, we know that human readers are imperfect, and there's quite a bit of inter-reader variability. But the low rates of lab-confirmed TB is a barrier to using a more robust reference standard, such as bacteriologic confirmation. And finally, the interpretation of CAD results in children. How do we use the CAD score to guide management in children? In adults, we use the CAD results to refer for confirmatory testing, but the lab testing is likely to be negative in children. So what do we do with this CAD score? How do we interpret it? So in conclusion, CAD is not yet ready for clinical use for TB in children, but there are promising results. And there's no doubt that CAD models will continue to improve with increasing access to pediatric chest x-ray data sets, which are currently being developed. The challenges for CAD are similar to the challenges for human readers in identifying TB on chest x-ray in children, detecting lymph nodes, accounting for image quality, interpreting the lateral view. And these challenges need to be addressed in order to generate a pediatric CAD model that is clinically useful. So overall, with improvements, CAD could have a significant role to increase TB diagnosis in children, to support the low expertise of readers, and address some of the challenges of chest x-ray interpretation in children. Thank you, and I just want to thank the study team at TB AlgoPed and also the tactic team for all your hard work and dedication. Thanks.
Thank you very much, Juno. Great. So we're moving away from diagnosis to treatment of TB in children now, which is also challenging. And I have the pleasure to introduce 2 presenters. First of all, Danica Gallivan, who has training in public health and community development, but lots of experience in research and data management, and she has been the medical research manager in the Philippines since 2022, where I've had the pleasure to work with her on this study and on CAD studies. And she has, yes, as I say, she's also done studies on content investigation and prevention, as well as the CAD and this study. The second speaker is online, so hopefully Dr. Cecilia Akatakwasa is with us from Uganda. Unfortunately, she couldn't make it in person. She's at the Epicentre Mbara site in Uganda, and she is a public health specialist and social and behavioural scientist. And over the last 12 years has been doing mixed methods and qualitative research in Uganda. And she is the senior research assistant at Mbara and has been involved in this study, but also other studies on the TB algoped that you heard earlier, and also on pediatric oncology. And she has experience in other areas, including adolescent sexual and reproductive health and women's health. Okay, so thank you, Danica. Please go ahead.
Thank you, Kathy. Good day, everyone. So we will be presenting the study findings on the implementation of the 4-month TB regimen for children in the Philippines and Uganda. TB remains a leading infectious cause of death in children globally, with 96% of pediatric TB deaths occurring in untreated cases. Until recently, as mentioned, the standard treatment duration for drug-susceptible TB in children was 6 months. However, following the results of the SHINE trial, the WHO recommended a shortened 4-month regimen for children aged 3 months to 16 years with non-severe drug-susceptible TB. This regimen is beneficial for the patients and TB programs. However, implementation has been limited and there is no available data on its feasibility and acceptability. Further, as Juno presented, classification of non-severe disease relies on chest X-ray, but is often unavailable and difficult to interpret. This slide summarizes the WHO eligibility criteria for the 4-month regimen. On the clinical aspect, children should not require hospitalization, have no dangerous signs, and may include those with HIV if no longer immunosuppressed. Nutritionally, there should be no severe acute malnutrition. These first 2 criteria must be met to be eligible for the 4-month regimen. Additionally, if confirmatory testing was done, expert and smear should be negative or show low bacterial load. And if chest X-ray is available, findings should be limited to PTB less than or equal to 1 lobe, without cavities or airway obstruction, and may include uncomplicated lymph node or pleural effusion. Note, however, that a child may still be eligible for the 4-month regimen even without these 2 diagnostics. So, our study aims to describe the implementation and assess feasibility and acceptability of the new 4-month regimen for non-severe DSTB. We also aim to assess among children and adolescents with DSTB the proportion eligible for the 4-month regimen and the proportion extending to the standard 6-month regimen, including its reasons. The study was conducted in 2 high TB burden settings. In the Philippines, the site was Tondo, an urban poor area with high population density, while in Uganda, a high TB HIV burden country, the study site is Barara, which was both rural and urban areas. We conducted a mixed method study among children with PTB. In Uganda, we included children under 10 years, as this was nested from the TB algoped study presented by Dr. Bashir. While in the Philippines, we included children under 16 based on WHO recommendations. For the qualitative component, we included patients, caregivers, healthcare workers, and key informants. For the qualitative data, we did focus group discussions before implementation, and then focus group discussions and in-depth interviews during implementation to compare how practices change after guideline adoption. For the quantitative part, we monitored children from treatment initiation to outcomes, at week 2, month 2, month 4, and month 6. Clinical assessments were done throughout follow-ups, and treatment decisions were reviewed over time to determine whether children would complete treatment at 4 months or required to extend to 6 months. We will now present the qualitative result.
In the qualitative results, we present findings on the description of the implementation in the Philippines and in Uganda. In the Philippines, the study was conducted in 10 primary health centers, and this was a pilot. At the time of the study or the pilot, the national guidelines for the public sector had been published but were not yet implemented, and the private sector was not yet engaged. Training was conducted by MSF for 1 day among doctors and nurses. Ongoing training is based on a cascade training model for where trained staff train colleagues. In Uganda, the study was conducted in 2 primary health centers and 1 regional referral hospital. At the time of the study, the national guidelines were still under development, but not yet published. Therefore, the study followed the WHO guidelines. MSF training was conducted for 4 days with clinicians and nurses, and ongoing training is based on continuous medical education, mentorship, and support supervision. Regarding perceptions of feasibility, in both countries, there was clear eligibility criteria which enabled feasibility with or without chest X-ray. MSF supported trainings enabled the feasibility of the study. Case report forms supporting clinical assessment of severity also enabled providers to conduct a severity assessment for patients who are eligible for shorter regimen. In the Philippines, however, further feasibility was enabled by availability of the chest X-ray, which was supported by MSF and other local partners. The challenge in the Philippines with the chest X-ray was that there was variable access to the chest X-ray, given the waiting times and travel times to sites where the chest X-ray existed. In Uganda, the main challenge was the lack of availability of the chest X-ray at the local lower-level health facilities, as well as a breakdown of the chest X-ray at the regional referral hospital. In both sites, the Philippines and Uganda, healthcare workers experienced turnover and transfers, and this limited continuity of implementation of the shorter regimen. Regarding healthcare worker acceptability, in the Philippines, providers presented key concerns around possible side effects as per the dosing of the day, per the daily dosing of the drug. And then there was also concern around severity assessment based on chest X-ray, which was affected by interpretation challenges as well as incomplete reports, which did not clearly indicate severity criteria. There were also concerns about sustainability if partners do not continue supporting the chest X-ray. In Uganda, on the other hand, there were concerns around assessing severity in the absence of chest X-ray, as well as effectiveness of the 4-month regimen versus the 6-month treatment. The drivers of acceptance of the shorter regimen included the fact that it was easy to integrate, given that the medications remained the same, and as well as the initial follow-up schedule. There was also flexibility to extend to 6 months in case the 4-month regimen did not work, as well as providers looking at positive patient outcomes as well as reactions regarding the shorter regimen. Next slide, please. Overall, the providers mentioned benefits of the shorter regimen, which included improved health outcomes, improved health outcomes, as well as reduced caregiver burden and reduced health system burden, as one provider from the Philippines presented in this court. That shorter regimen improves adherence, cost effectiveness, reducing the length of treatment, and can lower overall health costs, enhance quality of life. Shorter treatment can minimize the impact of disease and the treatment on a child's daily life. This was from a health worker in the Philippines.
Thank you, Cecilia. Moving on to the quantitative results. A total of 214 children were enrolled in the study. Children enrolled in Uganda were younger, with a median age of 1.9 years compared to 5.8 years in the Philippines. On chest X-ray availability, also the participants in the Philippines were able to undergo chest X-ray, while in Uganda, it was available for only around 56% of the study participants. On the eligibility for the 4-month regimen, Nearly 86% were initially assessed as eligible in the Philippines, whereas Uganda only half met eligibility criteria. This slide presents the non-mutually exclusive reasons why children required the standard 6 months. Severe acute malnutrition was higher in Uganda, affecting 25% compared with only 3.5% in the Philippines. Hospitalization also differed substantially, as no children in the Philippines required hospitalization at baseline, while almost 35% in Uganda did. On the radiological findings, 15 had findings of severe TB. Among this, the findings were non-mutually exclusive, with some children having more than one abnormality on chest X-ray. Lung opacity greater than or equal to 1 lobe was the most common finding, followed by pleural effusion. This slide further compares clinical and radiological severity among participants. Overall, among the 182 children with chest X-ray, 6 children were reclassified as not eligible for the shorter regimen based on radiological assessment. Finally, extension from 4 to 6 months occurred only in the Philippines among 7 children. The reasons included review of chest X-ray findings, diagnosis of community-acquired pneumonia, and persistent TB symptoms such as cough and weight loss during their follow-up consultations. Overall, 95% of the participants successfully completed their TB treatment. In conclusion, our findings from both the Philippines and Uganda demonstrate that the 4-month regimen can be successfully implemented, even in resource-limited settings. However, that depends on sustained accessible training, strengthened severity assessment capacity, reliable partner ecosystems, and clear context-adapted guidelines. Most children were eligible for the 4-month regimen under routine conditions, and importantly, eligibility determination was feasible even without chest X-ray. In our study, a low proportion required the standard 6-month regimen based on radiological assessment. These results highlight that the 4-month regimen holds significant promise for reducing treatment burden for families, but implementation should be scaled up. We would like to thank all our study participants, the research team, partners, these people, and institutions. That would be all, and thank you.
Thank you very much, Cecilia and Danica.
Merci, merci aux présentateurs.
Thank you to the speakers. How long do we have for questions? 10 or, okay, 15 minutes, let's say. 15 minutes for questions.
Il y a des gens très connus dans la salle.
There are some people who are very well known in the room, yet please do introduce yourself before asking your question. Saiba Beran, I'm a microbiologist, medical doctor. My question is to Dr. Bashir. Did you test the IGRA test for malnourished children? IGRA or IGRA?
Okay, go ahead.
Okay, thank you. No, we did not use that test in our study.
C'est trop cher, Saïd.
Too expensive, maybe, says Emmanuel.
Okay.
So the question was, do we use IGRA?
Ouais.
So
La question est sur l'IGRA et la réponse est non.
because
Yes, and the answer is no. The reason is probably the high price.
My question is also for Dr. Bashir. Sorry, I'm Johanna, leader of the pediatric working group. Thanks, Dr. Bashir, for a great presentation, really important work. 2 questions. One, proportion of patients with kwashiorkor, and was there a difference in outcome? Second question is the timing of the score. We know that it's incredibly difficult clinically in sick children with acute malnutrition. So can you make a comment on the time, whether you needed to adapt, not adapt the algorithm, but adapt the timing of the score in these children?
Okay, thank you for your questions. So for the kwashiorkor and the marasmic population, I think we have very few population of kwashiorkor, but I don't think there were much differences when it comes to treatment initiation. Then regarding the timing of the algorithm scoring. During our study in the different countries, Nigeria, Niger, and South Sudan, each had different timing. We did it based on the context. So, and this was influenced actually by the clinicians' acceptability. So in Nigeria, when we have high threshold of suspecting TB in that patient, we score immediately and then start TB treatment if it is more than 10. But if we have a bit lower threshold suspicion, then we delay it. But we do it within a week. That's the first scoring, so that we can treat some comorbidities, as we have a lot of sick children. But in Niger and South Sudan, we scored on the first day. But the clinician's decision actually helped, such that even when the score is more than 10, the clinician has the right to say, no, I want to see the child after a week again to score, even if the score is more than 10. So the third question? Okay,
Question
thank you.
de Marilyn. Tu es autorisée à pas te présenter, Marilyn.
Okay, merci.
Marilyn, maybe you don't have to introduce yourself.
So it's a comment and the question regarding the chest X-ray. So the question is for Juno. But the comment is just to say that despite all the issues with in addition to all the issues with the chest X-ray interpretation, I mean, one of the two main issues is access. I mean, there are most health centers where the TDAs are supposed to be used to decentralize pediatric TB cares do not have access to chest X-ray at all. And then, just to remind that national TB program do not cover expenses of the chest X-ray. They cover for the expert, but not the X-ray. So there is still a major issue of barrier to access. So then, just a comment for the third presentation. I don't know if you know, but the WHO, because of this problem of access, and the China trial, they were using part of their criteria, the chest X-ray. But then WHO experts, they issue some other recommendation without chest X-ray facing this issue of access based on clinically. And then from another study, we took different pediatric TB cohorts and we assessed the performance of the criteria without chest X-ray according to the experts' recommendation, and we compare with the SHINE criteria, the one you were using. And then we found a very low specificity. I mean, there was a lot of over treatment with the short course regimens with children with X-ray will not be eligible to the 4-month regimen. So I just encourage the PED-ALGO cohort to do the same exercise to compare with and without chest X-ray, because I think it will be quite interesting. And then the question for Juno is, I see that in your cohort, 78% of your children are SAM. And the SAM children, they have quite a specific chest X-ray presentation, a bit like advanced HIV-infected children. So I'm wondering how does it affect the performance results? And also in case of representativity, to generalize a bit to the overall pediatric TB presumptive population, and also just to remind that in adults, it's endorsed mostly for screening, not for diagnosis, and you have 86% sensitivity, which is not so bad for screening. Yeah, thank you.
Yeah, thanks for those great points. So about your first comments, I agree with you. There are a lot of barriers to this, including access, including cost, including chest X-ray quality, which I referred to, including interpretation. And I mean, just for example, we have sites that had quite poor chest X-ray quality. And so even though they had access to chest X-ray, in some cases we decided not to use the chest X-ray as one of the criteria. And so that's really something that's quite kind of lost in this, all these barriers that exist. And so we've been advocating for that with these WHO recommendations. There need to be more resources for access, for training for radiographers so they can improve the quality, as well as training for the clinicians. Your second question about SAM, that's a great question. I have not seen much specifically about the chest X-ray findings of SAM and how they differ, but I do believe if you look at the breakdown between the different countries, there's quite a difference in the population characteristics. In Uganda, it was a general pediatric population, whereas in Nigeria, most or all the kids had SAM. And so to make comparisons between the countries is quite difficult. But I do believe there will be a difference, especially as more research comes out, looking at these specific things. Some of these things have been looked at in adults. And for example, what they've seen in adults is the CAD does not perform as well in people living with HIV because of some of these factors that the chest X-ray appearance can be different, and in some cases they can be normal. Or another example, those who've had prior TB, CAD does not work as well. So I think as more research comes out, and I think we can contribute to this, we'll find more of these kind of factors that can influence CAD performance. Thanks.
Thank you for that comment. And just to also share, like, we really acknowledge the challenge in terms of access, but not only to access to chest X-ray, but the availability of chest X-ray, because you can have access, but sometimes the quality of images of the X-ray images are low, and it then becomes more difficult to interpret, especially for children. But as we have seen in our study, the findings show that only a low proportion of children required the standard 6 months because of radiological assessment. So really, even as Uganda did, only half were able to access chest X-ray, but they were able to assess the severity and the eligibility for the 4-month regimen as well. Thank you.
Merci. Mohamed Douti, je viens du Niger.
Mohamed Douti, I come from Niger. Those are beautiful studies. But still, back in 2008 at MSF, we always look at that score to diagnose TB in children. But the TB-LAM doesn't have a good sensitivity. And Fujilam as well, specificity is good, but sensitivity is not good with Fujilam. And it's still the score we use to diagnose TB in children, and it's only lung TB. And in these projects, you have other cases than lung TB, bone TB, lymph node TB, those are underdiagnosed. My question to Dr. Bashir, do you have more resources in the pipeline to diagnose this disease in children in a better way? Because those are pretty good results, but it doesn't solve the problem. You still have many cases that are underdiagnosed. And do you plan on doing some awareness to encourage practitioners to use that score? Because it's often because of that that the cases are underdiagnosed. Thank you.
Thank you for your question. You saw in our results that determined TB-LAM has low sensitivity as well as the specificity. The Fujilam has a good specificity, but not good sensitivity. So, and we do not, from the results, we don't recommend the use of the Fujilam for now, but as ruling test, it's a good test because of the good specificity. But the determined LAM, we do not support its use in HIV-negative children. But in HIV-positive children, I think it's already recommended by the WHO to use. So probably in the future, we could have a better TB-LAM point-of-care urine test that could have better specificity and sensitivity. But based on our results, we do not encourage its use in HIV-negative children. And regarding awareness to use the score, we've conducted, as we mentioned in this presentation, several trainings in MOH and MSF facilities or hospitals where the algorithms are integrated into care, especially nutrition facilities. And we also planned in our dissemination of the results plan to conduct more awareness in countries, in projects, and also internationally. I don't know if I... Yes, for extrapulmonary TB, this recommendation for WHO is basically for pulmonary TB. And extrapulmonary TB diagnosed majorly clinically, as we know. And in our study, we have not assessed that part of TB actually in our study. But we still recommend what is recommended in the text to use the clinical methods and if you have bacteriological testing to conduct it. But yeah, clinical diagnosis is the mainstay in extrapulmonary TB as well.
Alors, on a une question de Moutembi en ligne, hein, on a aussi des questions en ligne de Moutembi.
A question online from Mutembi in Gabon. In Gabon, we have a real challenge with TB in children, 4% in 2025. How can Epicentre help us to improve our figures in pediatric TB?
Alors, depuis 40 ans, quand on a ces questions, on fait ça.
Now, for 40 years, when we get this type of question, we do that. We hand over the mic.
This study really helps to confirm the utility of these treatment decision algorithms, which can be implemented in all settings and that do increase the number of children diagnosed. It's clear in the study results, it's clear in our programs as well. When you look at the numbers of children diagnosed with TB in 2025, they really do work. It's a lot of capacity building, and we're very happy to share experiences, and we're contributing to the WHO review of the diagnosis of TB in children, so they have an impact globally. But I really would encourage any country, especially in these times of changing humanitarian landscape with limited funding, this is a very good way to increase the number of children diagnosed with TB at very low cost. So I would really encourage that. Thank you.
Merci Moutembi pour la question. Oui, il y avait une question.
Thank you, Mutembi, for your question.
Okay, hi, Craig Tipple, I'm the medical director at DNDi. My question was for Juno, actually, about the computer-aided diagnosis. I mean, clearly a very powerful tool. One of your conclusions was that you needed more images to train the tool, and I was wondering how you were going to go about collecting those. And then actually more broadly, how do we go about collecting more images in general for training these sorts of tools, especially from neglected populations? And is there a role for MSF or Epicentre or DNDi, for example, in that, to make sure that we have the images we need to develop these tools for the populations that we're serving?
Yeah, that's a really good question and a very relevant one. Yeah, in terms of pediatric data sets, there are two consortiums which are collaborating. These are academic institutes with organizations like FIND who have have been for the past few years developing these chest X-ray data sets specifically in children. And there has been quite a bit of progress made. And the hope is that these data sets will actually be available publicly before the end of the year or in the near future. And the idea is that these can be shared with developers to develop new CAD products for children and also to test the current ones available. So there's been quite a bit of discussion over the past few years about MSF contributing data to this. And there have been some efforts made, led by Kathy, was involved in this, where there were some images actually that were shared with these specific consortiums. However, some agreements were made that they can be used to test data, but not shared with companies that would be using it for profit, unless some other arrangements were made, such as profit sharing, or is there a benefit to countries who will share this data. So it's kind of, there are discussions going on behind the scenes. I was at OCB Corridor Day, and this exact topic came up with the medical director, and so we're working on it. We do have to be very careful with patient data, and I think that's one of the big issues, especially with AI being more prevalent and the malicious use of data and dual use of data. Those are really important topics. So I know the data protection team at MSF, as well as the legal department, are involved in these discussions. The hope is that we can find a way to share data safely and responsibly, because I do think it's one of those cases that it will benefit everybody, benefit MSF, benefit our patients, but we do have to make sure we're doing it, with appropriate safeguards in place.
Thanks, Juno. Just one quick last question about why can't we get good quality X-rays in our projects?
That's a great question as well, and there are multiple factors involved. First of all, a lot of our projects are still using the old film and chemical processing, whereas in high income settings, it's all gone digital. This was decades ago, things have gone digital. And the quality of those will not be as good as a digital image. Other things are that, the radiographers, the technicians taking the images, they may not be trained radiographers. They may, come from a different background. They may be nurses or other medical staff who've been kind of given a very short, limited training on how to take x-rays because not enough emphasis is put on quality. And then the last issue, I think, is that, children are, it's difficult to get good quality images in children, as you can imagine. They're moving around, they're breathing, they're crying, and so it's a particular challenge to get good quality x-rays in children compared to adults who can follow directions and can hold still. So there are many challenges, but we're trying to tackle them one at a time. Thanks.
Thanks, Juno. Bien, je crois qu'on va s'en tenir là. Je vais remercier les présentateurs.
Thank you, Juno. I guess we'll leave it there. I'd like to thank all the speakers and the great work that you all did to prepare for this day. And I'd like to underscore again the great quality of the presentations. Thank you also for sticking within the allotted time. I look at Alain. We're like a great football team. We go on. Great. Thank you to all. Many thanks.